of factors like epithelial barriers, right? Skin is an example of an organ having the largest surface area. An easy question that you need to remember over here. We are going to be having the role played by phagocytes, neutrophils, and macrophages. And we are going to be having the role played by different types of cells like dendritic cells, the NK cells, and the complement proteins. Now, what has been asked in an exam relatively recently has been a question asking you about the markers for the NK cells. So you identify NK cells with the help of markers like CD16, CD56, and CD94. CD16, CD56, and CD94. That's what you need to remember. Second fact that you need to be having an idea over here is going to be the fact that we are going to be having special type of T cells over here, which are given the name of the gamma delta T cells. Gamma delta T cells are also a part of innate immunity. Why do I want to remember that fact is for the simple reason, whenever we are talking about adaptive immunity is going to be contributed by the presence of cells like the B cells as well as the T cells. So the basic fact that you need to remember is the majority of the T cells which are present over here, majority of the T cells that are present over here, they are the examples of alpha beta T cells. Alpha beta T cells. So just read the question carefully. Gamma delta T cells are a part of innate immunity, whereas alpha beta T cells are a part of adaptive immunity. Why is it important? Because B cells are going to be producing antibodies, and antibodies are going to be contributing to humoral immunity. Antibodies contribute to humoral immunity, humoral. Whereas T cells are going to be contributing to effector T cells, and they are going to be therefore contributing to cellular immunity. How are B and T cells going to be reacting with each other? How are APCs going to be reacting with the B cells is something that we'll be talking about shortly. But as of now, that's a very basic fact that you need to have an idea. And before we proceed further, let's just quickly recap these things. The T cell B cell ratio that you need to keep in mind over here has to be 3:1. That's an important thing. So T itself telling you 3. When you're talking about the T cell markers are classically from CD1 to CD8. We have additional markers like molecules which are going to be given the name of CD28. And we have a very important marker that is going to be given the name of CD40L. Why do we need to talk about this is the molecules that I've written in the red color are example of co-stimulatory molecules. CD28 and CD40L are example of co-stimulatory molecules. Between 1 to 8, which CD molecule is given pan marker? Pan T cell marker is a name that is given to CD3. CD3. Right? Similarly, if I'm talking about the B cell markers, the B cell markers are going to be around 19 to 23. 19, 20, 21, 22, 23. The co-stimulatory molecules that we are having over here are CD80, CD86, and CD40. So both of them interact with each other. Co-stimulatory molecules, CD28 interacts with CD28. So the way I remember this is 28. There are two molecules which are having alphabet, the numerical 8 in them. 80 maybe 8 aa hai, 86 maybe 8 aa hai. These are two important co-stimulatory molecules which are going to be interacting with the T cells. So 28 is going to be interacting with CD80 and CD86. Now, please remember in your NEET exam as well as your INI CT exam, what they may do in the exam is that CD80 and 86 are also being written by the second important name of B7.1, 7.2. B7.1 and B7.2. Hanji, 79 is also a marker of a B cell. CD79 is also a marker of B cells. Right? So this is a very basic fact that you need to have an idea. Which molecule is given the name of a pan B cell marker? Pan T cell marker was CD3. Pan B cell marker is the name given to CD19. CD19. That's what you need to keep in mind. Then we are talking about markers for NK cell. You already discussed. We just now said markers 16, 56, 94. Markers for NK cell 16, 56, 94. Not 96, my friend. 94, right? 41 and 61 are markers which are going to be useful for detection of megakaryocytes. 41 and 61 are marker for megakaryocytes. Right? So all of you are familiar with an example of a blood cancer in which megakaryocytes increase in number. That cancer is given the name of acute megakaryocytic leukemia. Acute megakaryocytic leukemia. It is seen classically in a patient suffering from Down syndrome. So if I ask you a question, how will I detect the presence of an acute megakaryocytic leukemia in a patient having Down syndrome? This is what you will remember as an answer, CD41 and CD61, right? The next thing that you need to remember over here is CD45RO. CD45RO is a marker for memory cell. It is a marker for memory cell. Just remember and read the question carefully. CD45RO in the exam is not to be confused with CD45. That was a previous All India exam question. CD45 is going to be given the name of leukocyte common antigen. Leukocyte common antigen, LCA. Leukocyte common antigen. So you need to be familiar with the T cell B cell ratio, the markers for T cell, B cell, NK cell, and you need to be familiar with confusing questions which are sometimes asked in the exam. Say for example, 45 and 45 RO. So 45 is for leukocyte common antigen, right? That is what you need to keep in mind. Next, जिसका marker होता है Dr. Ishaq, that is CD117, CD34 and CD117. CD34 is what you can make a mention of over here. CD34 is a marker that is useful for identification of hematopoietic stem cell. It's a marker for hematopoietic stem cell. Right, that is what he, Dr. Akshat, CD10 is a marker for naive B cells. Immature B cells का marker होता है. ठीक है, that is what you need to be familiar with. नहीं, 64 के एग्जाम में क्वेश्चन नहीं आया यार अभी तक ना. ठीक है. Then we are talking about the example of MHC molecules. Why is MHC molecules important? MHC molecules are having their genes which are expressed on short arm of chromosome 6. Right. The second that we need to remember over here is going to be given the name of the fact that MHC1 is going to be causing activation of CD8 T cells. MHC2 is responsible for causing activation of CD4 T cells. Why is it so? Because of the simple reason that whenever we are going to be talking about MHC1, this is the antigen binding cleft. So antigen over here in case of MHC1 is between two chains alpha 1 and alpha 2. And whenever I'm going to be talking about MHC class 2, the antigen over here is between two chains which are given the name of alpha 1 and beta 1. My humble request is read the question carefully in the exam. In case of MHC1 and MHC2, the antigen binding area are totally different. In case of MHC1, there is only one type of chain which is affected. One type of chain. Only alpha chains are affected. Alpha 1, alpha 2. That's how I remember it. In case of MHC2, there are two types of chains. Alpha chain also and beta chain is also affected. So alpha 1 and beta 1 is the area which is affected. Right? That's what you need to remember. Whenever we're going to be talking about the important fact, we need to remember that these chains are away from the cell membrane. So they are also being given the name of distal chains. This was a question asked in the INA exam earlier. Antigen binding area in case of MHC1 is distal alpha chains. Distal alpha chains means जो दूर है, alpha 1, alpha 2. Right? Another thing that you need to remember over here is that if you notice over here, there is a molecule that is mentioned which is given the name of beta 2 microglobulin. Remember this molecule, we will talk about this molecule in association with dialysis. We'll talk about this molecule in association with multiple myeloma. Right? Why multiple myeloma? Because this particular molecule is working as a prognostic factor. It is a very important prognostic factor in case of a patient having multiple myeloma. So this is a basic fact that you just need to keep in mind. Another important thing, whenever we are talking about MHC1, all of you know this fact, it is present on the surface of all nucleated cells. It is present on the surface of all nucleated cells. And it is also present on the surface of platelets. So even though it is a screening exam question, but hopefully you will remember the fact that it is not present on the surface of RBCs. It is present on all nucleated cells. MHC1 is present on the surface of all nucleated cells, also present on platelets. It is not present on RBCs. Okay. Whereas whenever we are talking about MHC2, MHC2 is present on all antigen presenting cells. It is present on all the antigen presenting cells. Physiology fact that which of the following antigen presenting cells is the most important. The most important antigen presenting cell that we need to remember is a dendritic cell. Especially the dendritic cell that is present in the skin. Dendritic cell in the skin is given the name of Langerhans cell. Dendritic cell in the skin is given the name of Langerhans cell. What are the other examples of antigen presenting cells? The other examples of antigen presenting cells are B cells. A third example of antigen presenting cells are macrophages. Third example of antigen presenting cells are macrophages. So even this very basic piece of information is going to be coming very handy for cracking questions in your exam. How is it going to come handy? Lot of these MHC molecules. MHC1 is known by another name. MHC1 is known by another name. It is having three parts: HLA, A, B, and C. It is having three subtypes: HLA, A, B, and C. Whenever we are talking about something like MHC2, MHC2 is also going to be having three parts. These are called as DP, DQ, DR. DP, DQ, and DR. Dr. Arun, DC was dendritic cell. Why is it important? Because certain types of HLA are going to be associated with certain types of disorders. Classical example, INI-CT question, which was asked to you in November 24. HLA DQ2, DQ8 patients, if they take wheat, they develop abdominal pain and diarrhea. DQ2, DQ8, if they eat wheat, they develop abdominal pain and diarrhea. So what is the disease we are talking about? Celiac screw. Right? That is what is asked as a question. Similarly, if I'm going to be talking about patients who are going to be having HLA-DR4, HLA-DR4, these are the patients who are going to be having high risk of development of rheumatoid arthritis. DR4, high risk of rheumatoid arthritis. That's a path orthopedics question. If I'm talking about a patient who's going to be having HLA-B27, B27, high risk of ankylosing spondylitis. With which particular drug there is a high risk of development of acute myocardial infarction. Therefore, you have to do this testing. With which drug do you do a testing for HLA-B51 so that the patient does not develop acute myocardial infarction? Very good. The answer is abacavir. Abacavir is which category of drug? Abacavir is which category of drug? It's of course an example of an anti-HIV drug. Which category? It is not an Avir, my friend. It's an example of an NRTI. It's an example of NRTI. It's an example of NRTI. NRTIs are going to be competitive inhibitors or non-competitive inhibitors? They are competitive inhibitors or non-competitive inhibitors? They are example of competitive inhibitors. Working against HIV1, HIV2. Every time you don't expect a question to be asking you about adenosine causing pancreatitis and stabudine causing peripheral neuropathy. That can be never be the way. Na? So they are going to be working as competitive inhibitors, and they are please going to remember that they are going to be working against both HIV1 as well as HIV2. HIV1, HIV2 दोनों पे काम करती है भाई और competitive inhibitor है. What is the most common side effect that you are going to be associating with a drug like which is an NRTI? NRTI का side effects क्या होते हैं? पैंक्रेटाइटिस करा सकते हैं, पेरिफेरल न्यूरोपैथी करा सकते हैं, लैक्टिक एसिडोसिस करा सकते हैं, राइट? दैट इज व्हाट यू नीड टू कीप इन माइंड. Which NRTI is responsible for causing stomatitis? Angular stomatitis. Stomatitis. That is something should be known to you. Very good, Varsha. Excellent, Shelly. Zalcitabine. मुंह जल जाता है ना? I hope you remember that fact. Zalcitabine. Right? Which is an example of a nucleotide NRTI. ये तो आसान है यार, ये बता दोगे तुम. न्यूक्लियोटाइड NRTI कौन सी है? Shabash, tenofovir. So we are on track, right? Coming back to the discussion, this is what we need to be familiar with MHC, right? Now we are talking about APC and T cell activation. So this is exactly what is going to be happening. I want you to focus on this kind of an interaction that is going to be taking place. This is what is going to be given the name of a primary interaction. So primary interaction is between MHC molecule. You have antigen over here. You have a T cell receptor, right? But this is going to be giving only signal one. This is only the first signal. You also require a second signal. You also require a second signal, which is given the name of signal 2. What is signal 2? Signal 2 is basically co-stimulatory signal. So we discussed the fact what is a co-stimulatory molecule on the surface of T cell. The co-stimulatory molecule on the surface of T cell is CD28. How is it going to be interactive with? जहां पे भी 8 आ रहा है, दो numbers में 8 आता है, 80 और 86. What is the other name given to 80 and 86? B7. So co-stimulatory molecule that is acting over here is with co-stimulatory molecule of macrophage, that is B7. So when both the signals are present, only then the T cell is going to get activated. The classical example I keep on talking about, driving your car, driving your bike. You start the engine of the car, that is signal 1. You start the engine of the car, that is signal 1. You put the car in the gear, that is signal 2. So once you start the engine and put the car in the gear, only then the car is going to move. So this is signal 1 and signal 2. That is what is important. right? Only then the T cell is going to get activated. Now, in a similar fashion, if I talk about interaction between B cell and T cell, B cell is also an example of a APC, and it is also going to interact with T helper cell. T helper cell is also given the name of CD4 T cell. CD4 T cell is going to be interacting with MHC2. So this is what I would call as the first interaction, the primary interaction. This is first signal. This is what I would call it as the second signal. Why is it going to be of importance? For the simple reason. Whenever you're going to be having the first signal as well as the second signal, this is what is going to be responsible for secretion of interleukin 4 and interleukin 5. Why is interleukin 4 and interleukin 5 going to be important? Because the first antibody produced by B cell is IgM. And after some time, the antibody produced by the B cell is IgG, IgA, and IgE. What is this phenomena called as? All of you know that fact. It is given the name of isotype switching. Isotype switching. Change in the nature of antibody. Antibody switching or isotype switching. Why is the isotype changing? Why is the antibody changing? Because of interleukin 4 and interleukin 5. Why is interleukin 4 and interleukin 5 secreted? Because of interaction of co-stimulatory molecule. So easy for you to remember an INI question as well as a NEET question. If a person is going to be having a defect over here, if a person is having a defect over here, defect in B cell or defect in T cell, then interleukin 4 and interleukin 5 cannot be secreted. If these cannot be secreted, there is a block over here. And if there is a block over here, this person is going to be secreting or producing only one type of antibody, which is given the name of IgM antibody. So yes, we are talking about a condition which is given the name of hyper IgM syndrome. There can be two reasons for hyper IgM syndrome. It can be a B cell problem or it can be a T cell problem. What is the problem which can be seen in the B cell? The problem in the B cell can be CD40 problem. What is the problem that can be seen in the T cell? There can be a problem in the CD40L. CD40L. So I hope you remember the fact that CD40 is what is going to be present on the B cell. CD40L is what is present on the T cell. So remember T for testicular tissue, T for T cell, testicular tissue. And testicular tissue has got a very good relationship with L. Before your dirty mind starts working, L means Leydig cells. Leydig cells. So testicular tissue and Leydig cells are going to be related. That is how you remember CD40 is what is going to be related with B cell. CD40L is what is going to be related with the T cells. And I hope this imagination helps you in the exam as well, whatever way you wish to remember. But any problem with the CD40, any problem with the CD40L is what is going to be causing hyper IgM syndrome. So this is what they have asked you as a question in the exam earlier as well, right? So this is the first question which was asked in the exam, defect in this interaction. And the second question that I asked in the exam was absence of CD40. The answer for them is same, hyper IgM syndrome. Hyper IgM syndrome, right? Now, these are example of molecules which are going to be stimulatory in nature. There is a possibility that some molecules are going to be acting like a brake. Some molecules are going to be acting like a brake. What are the molecules which can be acting like a brake? Say, for example, we have a molecule that is going to be working, which is going to be given the name of CD28 over here, and interacting with a molecule that is given the name of CTLA4. If CD28 interacts with B7, then it is going to be increasing the activity. If CD28 interacts with CTLA4, it is working like a brake. So activation is going to be decreased. These are called as inhibitory molecules. Similarly, you have heard of interaction between molecules which are given the name of PD1 interacting with PDL1. PD means program death. PDL1 means program death ligand. So program death ligand 1 interacting with program death receptor. This is also going to be acting like an inhibitory receptor. Inhibitory receptor. This was the basis of question which was asked in the November 24 INI-CT exam. So they talked about co-stimulatory molecules. B7 and CD28 are co-stimulatory. They talked about CD40 and CD40L. They are also co-stimulatory. They talked about release of cytokines, which are also going to be responsible for increasing activation. But when we are talking about PD1 and PDL1, they are inhibitory in nature. That is what you need to keep in mind. So this is what is going to be given the name of immune checkpoint. You cannot constantly activate immune system all the time. You have to put a brake also on it. You have to check also on it. So that is an example of an immune checkpoint. This mechanism of break is especially important because tumor cells, cancer cells, they inhibit the immune cells of the body by this mechanism. They break or they inhibit the immune cells of the body by this mechanism. So that is why cancer cells are able to survive. So the pharma correlation, all of you know that pembrolizumab, nivolumab are example of drugs which are going to be responsible for inhibiting this interaction. So they will not be able to break the immune checkpoint. Right? That's what you need to keep in mind. ठीक, आगे बढ़ते हैं. This is an example which was given in the exam, which has been known to most of you. So normally we are going to be having the example of normal representation. Normal means these are the cells. They are CD40 and CD19 positive. 19 positive, 40 positive. But when we are looking at a patient, these are the cells that we are talking about. So these cells are CD19 positive, but these cells are CD40 absent, CD40 deficient. So that means these are example of B cells in which CD40 is absent. And that is why this is a patient who's going to be suffering from what kind of syndrome? This is a patient who's going to be suffering from a condition which is given the name of hyper IgM syndrome. So they've asked you this question in the form of an image-based question, in the form of a flow cytometry pattern. They've asked you this question in the form of a theoretical one-liner question as well. The same story, the same concept. That interleukin 4 and interleukin 5 is responsible for causing switching in the nature or the class of the antibody. This is the basic point that you have to keep in mind. I hope that's easy. Talking about then the concept of tolerance and autoimmunity. Tolerance means that the immune system is not going to work against self. Immune system is not going to work against self. This tolerance can be of two types. Either it takes place in lymph node and the bone marrow. If it takes place in lymph node and bone marrow, it is thymus and bone marrow. Do excuse me on that. Thymus and bone marrow. Then it is given the name of central tolerance. Right? पॉजिटिव नेगेटिव कैसे देखा? देखो ग्राफ में देख लो. 19 मतलब एक्स एक्सेस पे. जितना ज्यादा राइट साइड पे होगा उतना ज्यादा एक्सप्रेशन है. तो 19 का एक्सप्रेशन है इन वाले सेल्स के अंदर. ये 19 पॉजिटिव हो गए. एंड जितना आप देखोगे वर्टिकल एक्सेस में जितना ऊपर होगा उतना एक्सप्रेशन ज्यादा है. तो जब आप एक्स एक्सेस वाला देखोगे तो आपने राइट साइड देखना है. ये जो लाइन है इसके राइट साइड पे अगर आप देखोगे राइट साइड पे है, इसका मतलब हाई एक्सप्रेशन ऑफ CD19. To see for the x-axis parameter, look at the location of the cells. They have to be on the right of this vertical line. To see for the y-axis parameter, ये basal line है, ये basic line है. इससे ऊपर होने चाहिए cells. That's why they are positive. I hope that is clear, युतिका. पर्पल जो होते हैं ये हमारे टेस्ट सेल्स हैं, ये हमारे रेफरेंस सेल्स हैं. राइट? तो यहां पे जब आप देखते हो, यहां पे आपने देखा राइट साइड पे तो है, मतलब CD19 तो है, बट इस लाइन के नीचे है. दे आर बिलो दिस लाइन, सो दे आर CD40 नेगेटिव. 40 ये वाला था ना, इसके कम है ये. ठीक है, दैट इज व्हाट यू नीड टू कीप इन माइंड. नहीं, 19 का मतलब है बी सेल की बात हो रही है. 19 का रोल यहाँ पे पैन बी सेल मार्कर है ना, तो हम पैन बी सेल की मार्कर है, तो इसका मतलब है यहाँ पे बी सेल की प्रॉब्लम है. इट्स अ बी सेल डिफेक्ट. दिस ग्राफ इज रिप्रेजेंटेटिव ऑफ अ बी सेल डिफेक्ट. दैट्स व्हाट यू नीड टू कीप इन माइंड. हाँ जी, आइडियली नॉर्मल सेल्स शुड बोथ बी इन क्वाड्रेंट 2. हाँ जी, हाँ जी, पर्पल वाले रेफरेंस सेल्स है ना यार, पर्पल वाले रेफरेंस सेल्स हैं. ये सेल अंडर स्टडी है, ये आपको चीज ध्यान रखनी है. ठीक है. Now, talking about tolerance, tolerance can be of two types. If it is seen in thymus and bone marrow, it is called as central tolerance. If it is seen in the lymph node, if it is seen in the lymph node and the peripheral lymphoid organs, then it is going to be given the name of peripheral tolerance. Central tolerance has got multiple mechanisms. You look at your notes, you have an idea. Central tolerance is going to be having different mechanisms. One is negative selection or apoptosis. Negative selection or apoptosis. Second is receptor editing. Change in the shape of the receptor. Change in the shape of the receptor. It is applicable only for B cells. Remember this fact. This was a previous NEET PG question. Apoptosis and negative selection can be for both B cells as well as T cells. Receptor editing is only for B cells. And third one that we need to remember over here is that you are going to be having the presence of a gene which is going to be controlling the activity of the cells. This gene is going to be given the name of AIRE gene. This gene is going to be given the name of AIRE gene. What is the function of the AIRE gene? AIRE, autoimmune regulatory gene. This controls the activity of T cells. It controls the activity of T cells. So if an individual by default, by mistake produces autoimmune T cells, the AIRE gene is going to control it. Suppose somebody is not as lucky as you and me. That's why I keep on talking about the fact. I keep on repeating that fact. We are very lucky. We are very lucky. We are very lucky. पूरी रॉबिन्स बीमारियों से भरी हुई है, पूरी हैरिसन बीमारियों से भरी हुई है. अपने को तो उनमें से 99.999% नहीं है यार. तो हमें किस बात के लिए दुखी होना है? हमें तो काम करना है. सो अगर हम देखेंगे ऐसे इंडिविजुअल्स को जिनके अंदर AIRE जीन डिफेक्टिव हो जाता है, so that is not going to be able to control the T cells. And if it is not able to control the T cells, the patients are going to be suffering from a syndrome which is going to be given the name of autoimmune polyendocrinopathy syndrome. This was again the question which was asked in the INICT mid exam. So these are the patients who are going to be having fungal infections. T cells काम नहीं कर रहे तो fungal infections का risk बढ़ जाएगा. Mucocutaneous candidiasis. Patients are going to be having the presence of a problem in the parathyroid gland. Patients are going to be having a problem in the adrenal gland. They are going to be having a problem in the pancreas also. So reduce activity of the adrenal, so adrenal insufficiency, reduce activity of the parathyroid, hypoparathyroidism, T cells are not functioning, so increased risk of candidiasis, mucocutaneous candidiasis, and the patients are going to be having high risk for development of diabetes mellitus. This is what you need to remember. Right? What is the component of peripheral tolerance? Peripheral tolerance. Peripheral tolerance is something that is going to be seen in the lymph node, in the spleen, in the bone marrow. It is going to be associated with one is energy. Energy का मतलब होता है loss of energy. Energy means loss of energy. So whenever we're going to be talking about energy, energy is because of decreased activity of CD40 or decreased activity of CD40L. Energy. T cell energy or B cell energy. That means they will not be able to interact properly. Apoptosis. Apoptosis means destruction. Programmed cell death. So that means negative selection. Negative selection. And the third example of mechanism that you need to remember over here is regulatory cells. Very importantly asked in the exams. These are called as T-reg cells. T-reg cells. T-reg cells are example of cells which are responsible for having an important function. They secrete interleukin 10. They secrete TGF-beta. So because of which they are responsible for decrease in immunity. I hope you are able to recall that from our main video discussion as well as in the mission class. That interleukin 10 and TGF-beta are example of anti-inflammatory molecules. They are responsible for decreasing the activation of immune cells. Yes, they are going to be having the role played by FOXP3. The other thing that we need to remember over here is there is a concept of what is given the name of immune privilege site. So of course I say, I bet you know the answer. And when I say I bet you know the answer, this is the bet I'm talking about. B for brain, E for eyes, and T for testicular tissue. These are immune privilege sites. That means that there is some kind of a barrier, blood ocular barrier, blood testicular barrier, blood brain barrier. So there is a barrier because of which immune cells are not able to reach over here properly. And because the immune cells are not able to reach over here properly, so these antigens are hidden antigens. That's why they are using the term immune privilege sites. So when you have a traumatic injury, let us say the eye, the other eye also gets inflamed, sympathetic ophthalmitis. Similarly, you have something which is called as sympathetic orchitis. Right? So these are the four mechanisms of peripheral tolerance. So three mechanisms of central tolerance. Three mechanisms of central tolerance. Right? हाँ, आंखों से जब एक्टिवेशन होता है तो दो ही जगह सिग्नल जाता है, वो दोनों जगह का ध्यान रखना है, वो प्रिविलेज है, ध्यान रखना है. So when we are talking about central tolerance, we are going to be having three mechanisms: negative selection, receptor editing, as well as we are going to be having a role played by AIRE gene. When we are talking about peripheral tolerance, it is going to be having four mechanisms. These are energy, apoptosis, T regulatory cells, and immunoprivilege sites. Any kind of a failure of this, any kind of a failure, if tolerance fails, the person is going to develop autoimmune disorders. If tolerance fails, the person is going to be having autoimmune disorders. Hypersensitivity reactions, nothing for me to discuss at this point of time. That's easy. Type 1 hypersensitivity involves IgE antibody. First time antigenic exposure, no clinical symptoms develop. Second time antigenic exposure, patients are going to be having activation of the mast cells. And the examples are what are very important. Examples remembered with the classic acronym. Now that has been obviously available to you for the last 18 years or so. ABCD. So allergy, atopy, bronchial asthma, Cassoni's test, and drugs. Right? Just remember in the drugs, we have the important example of a drug that is going to be given the name of penicillin. Right? That is what you need to remember. Hanji. Autoreactive, Dr. Michelle, autoreactive B cells, autoreactive T cells are destroyed in both. Right? So classical history that they give in the exam time and again is a guy who's going to be, let us say, going on a beach. He's eating seafood. After that, he develops rashes and he's developed bronchospasm. Person is going on a visit. He is going in a weather where there is a lot of pollen inhalation. Then he is developing bronchospasm. The person is going to be eating something. He's going to be developing a gastroenteritis. He's going to be having edema of the bowel. So any kind of a intake of allergy, any type of intake of an allergen is responsible for causing a degranulation of the mast cell. And that is what is going to be associated with the type 1 hypersensitivity reaction. When we are talking about type 2, the antibodies over here are different from type 1. They are IgG or IgM. Now, these are example of conditions in which the antibodies are responsible for activation of the immune system. They are responsible for activation of the complement system, which is going to be responsible for causing death of the tissue or decreased activity of the receptor. So these are the examples that we keep in mind. My blood group is Rh positive, and all those examples have been asked in the exam. Your recent exams had the example of pemphigus vulgaris. This was a skin and path question. It was given as a direct question also. Fishnet pattern, if you remember. Fishnet pattern. And it was given as an example of an image-based question also. Then we got a question in the exam on blood transfusion reaction. That was also a classical question asked in the exam. This is classically mismatched blood transfusion reaction. Mismatched blood transfusion reaction. Yes, Dr. Astral Cortex, you are right. Tombstone appearance on immunofluorescence. Pemphigus vulgaris has tombstone appearance on immunofluorescence. So we have examples like myasthenia gravis, blood transfusion reaction, good pasture, Graves' disease. Graves' disease, all-time favorite of your examiners. Immune hemolytic anemia was again asked as a question. RH incompatibility, hyperacute transplant ejection. Type 3 is what is given the name of immune complex disease. It's called as immune complex disease. So what we are having in this kind of a condition is that antigen antibody complexes are present. This is going to get deposited in certain areas in the body. For example, joints, for example, skin, for example, kidney, for example, serosa. And over there, they activate complement. They activate complement after depositing in the tissues. So they cause local damage. So this is going to be seen in case of conditions like the SHARP conditions. That's the acronym that we are using for remembering these conditions. The commonest example which is tested on your exam happens to be SLE, systemic lupus erythematosus. Another example can be serum sickness. You can remember one example from microbiology that is given the name of Schick test. Schick test is what you do in case of Corynebacterium diphtheria. Corynebacterium diphtheria. We have condition which is given the name of Hinox-Schönlein purpura. It is now called by the name of IgA vasculitic disorders. IgA vasculitic disorder. We then have a condition that is given the name of Arthus reaction. It's a type 3 hypersensitivity reaction affecting the small blood vessels. Then we have examples like reactive arthritis, and we have examples like PSGN and PAN. PSGN is post-streptococcal glomerulonephritis, and PAN means polyarthritis nodosa. There is, yes, Dr. Pradyuman, you are absolutely right. There is an example of a immunological assay which was asked in the exam earlier. That is what was given the name of Raji's assay. But we haven't got a question on this one in the last exams, last at least 4 to 5 exams. So we can skip that, of course. But if you wish to remember, of course, if you know about them, that's going to be really good, right? Reactive arthritis, Raji's essay, that is what you need to remember. Right? RA, Raji's essay. एक R तो reactive arthritis हो गया RA. एक RA आप ये रख सकते हो Raji's essay. The only thing that you need to keep in mind is this RA is not to be confused with rheumatoid arthritis. This RA is not to be confused with rheumatoid arthritis. Rheumatoid arthritis is an example of a type 4 hypersensitivity. Multiple times, same question. In case of rheumatoid arthritis, there is no involvement of antibody. In case of rheumatoid arthritis, there is no involvement of antibodies. So it's an example of a cell-mediated hypersensitivity. Majority of the cells that are involved over here are Th1 cells. But there can be a role that is going to be played by CD8 T cells as well. Th1 cells as well as CD8 T cells are going to be playing a role. Common example of conditions which are tested on your exams include dermatology conditions like contact dermatitis. That is seen because of chemical detergents and artificial jewelry in case of females. We can be having condition like type 1 diabetes. We can be having condition like rheumatoid arthritis. We can talk about a condition like inflammatory bowel disease, especially over here, Crohn's disease. And we are talking about a condition over here which is going to be given the name of psoriasis. So the usual way of asking the question in the exam is that they will give you clinical history. And depending upon the clinical history, you have to answer a question that what is the hypersensitivity which is going to be involved over here. Hypersensitivity reaction that is going to be involved over here. Right? So this is an important thing that you need to remember. Yes, Dr. Mahesh, if you read Harrison, it makes a mention of rheumatoid arthritis having a component of immune complex as well. But if you're going to be talking about Robbins, and Robbins just makes a mention of rheumatoid arthritis as an example of a delayed type hypersensitivity reaction, type 4. Yeah, of course, we are going to be talking about multiple sclerosis as well, doc. Right? Now, the next one is going to be graft rejection, which is going to be easy. These are the different types of grafts, which is an easy question asked in the exam. If you're taking a graft from self, say for example, skin transplant, bone transplant, or hair transplant, it's an example of an autograft. I don't have to explain this much. If you're taking a graft from something like antibody from an identical twin, that is given the name of isograft. Iso means identical twin, right? Doc, antibody is present, but antibody is seen because of abnormal activation of the B cells by the CD4 T cells. So T cells cause maximum damage. Antibodies are surrogate damage causing particles. Then we are going to be talking about all twins, identical twins. Identical twins का दूसरा नाम होता है monozygotic twins. If you are going to be taking a graft from the individual from the same species, this is the commonest type of transplant that is being done, particularly in case of a transplant like kidney transplant, liver transplant, cardiac transplant. These are example of typically allografts. And if you're going to be taking a graft that has been taken from a different species, say for example, cardiac valves, right? So that is going to be an example of a xenograft. Now, if you're going to be putting a graft, there is a possibility the graft is going to be rejected. This is the body of the host. This is the graft that you are putting up. So the immune cells of the host, they start attacking the graft. If the immune cells of the host start attacking the graft, that is given the name of graft rejection. Right? If that is going to take place within a span of few minutes to hours, it is called as hyperacute graft rejection. Most commonly asked question in the exam is on this one. This is because of preformed antibodies. This is typically because of preformed antibodies against the donor. One of the common reasons for having this is blood group mismatching. One of the commonest reasons for having hyperacute transplant rejection is blood group mismatch. So these antibodies will go and cause damage to the endothelial cells. That is going to result in clot formation, and therefore the graft is going to be rejected within minutes to hours. The second one that we talk about is acute rejection. That can be because of antibodies or that can be because of cells. If it is because of antibodies, then this is going to be responsible for causing complement activation. And if it is because of complement activation, then complement C4D is going to get deposited in the kidney. Complement C4D is going to get deposited in the kidney. So you were asked an INI-CT question, which is a very high probability of being repeated. Which of the following is a marker for acute humoral rejection? The marker for acute humoral rejection is C4D in the glomeruli. In a patient having acute kidney transplant rejection, what is a marker for acute humoral rejection? The answer is C4D deposition in the glomerulus. These patients are going to be having the rejection that is going to take place within a span of weeks to months. Typically, the time that is going to be taken over here is going to be less than 6 months. Less than 6 months. So days to weeks, but less than 6 months. If a transplant is going to be rejected after 6 months, it is given the name of chronic transplant rejection. Chronic transplant rejection. So over here, the problem is attack by the T cells, attack by the antibodies. And because of the attack by the T cells and the antibodies, there is ultimately fibrosis of the vessels, fibrosis. So this is what you need to remember. This is clinically the most common type of transplant rejection that is seen. Commonest type of transplant rejection that is seen clinically is chronic transplant rejection. You have been asked two more questions. How can we decrease the risk of transplant rejection? How can we decrease the risk of transplant rejection? The first method is gene matching. In gene matching, you have to do HLA matching. In HLA matching, the most important HLA which has to be matched is HLA-DR. So ideally, you should be taking the donor and the acceptor should be having the same blood group. Second thing, as a good doctor, that's what I always say, as a good doctor, remember, DR matching has to be given top priority. DR matching has to be given top priority. You have a scoring system, 6/8 scoring system or 4/6 scoring system. But just remember, the more the score, the DR matching is mandatory. Blood group has to be matched, DR mandatory. Second thing that you do is that give immunosuppressive therapy. Immunosuppressive therapy. So you kind of weaken the host system's immune response so that it is not going to attack the graft. Right? And these are the example of drugs that you're already familiar with. Tacrolimus, cyclosporin. Tacrolimus, cyclosporin. Right? So they are example of, or mycophenolate mofetil, MMF. Right? Not MMS, MMF, mycophenolate mofetil. These are example of immunosuppressive drugs. So they are responsible for decreasing the immunity of the host. Right? Yeah. Calcineurin inhibitors, and they are going to be responsible for decreasing the activity of the immune system. Right? That's what you need to remember. Then we have something that is given the name of graft versus host disease. The graft starts attacking the host. If that takes place within a span of 100 days, then that is given the name of acute reaction. And if it is going to be attacking the host after 100 days, it is given the name of chronic graft versus host disease. These are the example of tissues which are most commonly affected in case of graft versus host disease. The first tissue that is affected, that's a commonly asked question, skin. So first manifestation of graft versus host disease is going to be skin rash. First manifestation of graft versus host disease is going to be skin rash. That's a commonly asked question. The second important organ that is going to be affected in the patients is going to be involvement of the intestine, bowel. And the third one that you need to remember over here is going to be liver. Liver is involved in the last. Liver is going to be involved in the last. That is what you need to remember. Right? Skin, bowel, and liver. So clinical presentation of the patient is in the form of a skin rash. Patients are going to be developing a diarrhea, typically a bloody diarrhea, and patients are going to be having a development of jaundice. That is what you are going to be seeing or observing in case of a patient having graft versus host disease. Which type of grafts are going to be having a high chance of development of graft versus host disease? This is typically going to be applicable in case of a condition like bone marrow transplant. BMTs, bone marrow transplant. Example of a solid organ transplant which is going to be responsible for causing graft versus host disease is going to be hepatic transplant. Hepatic transplant. Yes. And we are talking about a criteria by which you can make a diagnosis of severity of the graft versus host disease that is given the name of Billingham's criteria. You already have it in your notes. आपने नाम याद रखना है Billingham's criteria. It is associated with graft versus host disease. Billingham's criteria is associated with graft versus host disease. Right? Which is the type of graft which is going to be having the maximum chances of survival? In case of solid organs, kidney transplant. Kidney transplant, maximum chances of survival. Which type of graft is going to be having lowest chances of survival? Pulmonary graft. Pulmonary transplant. Pulmonary transplant. Right? Another question which was asked in the exam is, whenever you're going to be having a patient who has undergone an organ transplant, the patients are going to be having immunosuppression. So they are at high risk for developing infections. And one of the infections which is commonly asked in our exam is CMV infection, cytomegalovirus. So after kidney transplant, patients are at high risk for development of CMV nephritis. CMV nephritis. How do you make a diagnosis? These patients are going to be having in the kidney biopsy, they're going to be having the presence of Aula appearance of CMV. Aula appearance of CMV. Second fact that you need to remember is whenever you're going to be having an organ transplant, and because of which there is going to be a decrease in immunity, this is also going to be associated with a high risk for development of malakoplakia. This was your INI question which was given in the exam. Malakoplakia. Malakoplakia is an example of an infection that is going to be associated with Escherichia coli infection. It is seen typically in case of suppressed individuals. Yes, you are right. Malakoplakia most of the times affects bladder, but it can take place in extra sites also. It can take place outside the urinary bladder also. And what was asked to you as a question in the NEET exam was about involvement of the skin. How do you diagnose? It can cause involvement of the skin as well. It can cause cutaneous malakoplakia. But what you need to remember is whether we are talking about involvement of the urinary bladder or we are talking about the involvement of the skin, you have a common finding, which is the presence of Michaelis-Guttman body. We'll talk about Michaelis-Guttman body later also. But as of now, this is the basic thing that you need to just keep in mind. So organ transplant history, immunosuppression history can be associated with high risk for development of infections, can be associated with the development of malakoplakia as well in the patients, which can be cutaneous malakoplakia, or it can be an example of vesical malakoplakia. That means involvement of the urinary bladder. I hope that is clear to you. Then talking about detection of antibodies, so many antibodies are present. And the question which was asked in the exam is, which is the method by which you are able to detect the presence of antibodies, right? Which is going to be seen. So one of the methods by which we detect antibodies is going to be with the help of direct or indirect immunofluorescence. Between direct and indirect immunofluorescence, which of them is going to be better? Please remember it is indirect immunofluorescence. Indirect. The reason is in case of indirect immunofluorescence, you are going to be having amplification of signal. Amplification of signal. डायरेक्ट में वन मॉलिक्यूल के साथ में वन एंटीबॉडी बाइंड करेगी, सो इट इज वीकर. इट इज वीकर. एंड इन केस ऑफ इनडायरेक्ट, what you're going to be having over here is that with one antibody you can have attachment of multiple antibodies over here, so amplification of signal, right? So in case of tissues, that's a fact that you need to remember. In case of tissues, the way of detection of the autoantibodies is in the tissues that is best done with the help of indirect immunofluorescence. Indirect immunofluorescence. ELISA के अंदर तो you are going to be taking the blood sample of the patient, detecting the antibodies directly ना. यहाँ पे टिश्यू के अंदर आपको डिटेक्ट करनी है एंटीबॉडीज, whether the antibodies are present in the tissue or not. So you can have DIF or you can have indirect immunofluorescence. Then there is a question asked in the exam talking about the presence of different types of anti-nuclear antibodies which are going to be having specific pattern. Out of it, the most commonly asked question in the exam happens to be this one. Nucleolar. Centromeric and nucleolar are the most common patterns which have been asked in the exam. So they will talk about a history of a patient who is going to be suffering from, let us say, some kind of vascular phenomenon. And then this patient is going to be having the features associated with the development of CREST syndrome. Calcinosis, there is a esophageal dysmotility, there is a presence of sclerodactyly, there is a presence of telangiectasia. So these are the patients who are going to be having the presence of centromeric and anti-centromeric antibody. Right? That's what you just need to keep in mind. CREST syndrome, anti-centromeric antibody. Just to have a quick recap, these are the different antibodies which are asked in the exam. So I'll omit it, but I would just like you to highlight the fact about SLE. The sensitive antibody over here happens to be ANA, generic ANAs. The specific antibodies are anti-dsDNA, anti-Smith. Which of them is more specific? Anti-Smith. If a patient is going to be having SLE and the patient is having anti-phospholipid antibodies, then these are the patients who are at high risk of suffering from APLA syndrome. Young female recurrent abortions and having presence of multiple miscarriages, APLA syndrome. Young female multiple abortions having the presence of SLE, having APLA syndrome. In case of systemic sclerosis, if I'm talking about CREST syndrome, this is CREST syndrome. Or the patients could be having anti-topoisomerase antibody, which can be seen in patients having systemic sclerosis. Total organ involvement, systemic sclerosis. Diffuse scleroderma. So centromeric is CREST syndrome, CNC. Total organ involvement is diffuse scleroderma, that is systemic sclerosis. Remember the fact, if a patient is going to be having systemic sclerosis and the patient is having high chance of kidney failure or acute onset of scleroderma crisis, this is indicated by anti-RNA polymerase antibody. The antibody over here is RNA polymerase antibody. Acute onset scleroderma renal crisis. Very, very important question for the exam. INI question, a patient is having presence of anti-histidyl amino tRNA synthetase. I am just highlighting what was asked as a question. This was asked as a question. The answer is a patient of autoimmune myositis. It's a patient of autoimmune myositis. RNA polymerase antibody is associated with RNA polymerase antibody is associated with acute onset of scleroderma crisis. अगर आपका पेशेंट है सिस्टमिक स्क्लेरोसिस वाला, उसको आरएनए पॉलीमरेज एंटीबॉडी है, तो इसका मतलब है पेशेंट कैन गो इनटू सडन सिवियर हाइपरटेंशन. दैट इज व्हाट इज गिवन द नेम ऑफ स्क्लेरोडर्मा क्राइसिस. If a patient is going to be having autoimmune myositis, he is expected to have this antibody, which is given the name of anti-Jovan antibody. It is also called as histidyl tRNA synthetase antibody. ये पुराना नाम था जोवन एंटीबॉडी, जो आपके क्यू बैंक्स में प्रेजेंट है. द क्वेश्चन आस्क्ड इन द आईएनए एग्जाम वाज anti-histidyl amino acyl tRNA synthetase. Histidyl amino acyl tRNA synthetase. You write down the name of the conditions, write down the name of the antibodies on the right side, have a look at this chart time and again repeatedly. That's the easiest way to remember it. When I say easiest, this is what people find as the easiest. Rheumatoid arthritis, anti-CCP antibody. Anti-CCP antibody. Right? So the nutshell is that you have to remember about the name of the antibodies and the specific conditions. The specific conditions that are going to be associated with them. कितने चार्ट बनाए? बहुत सारे चार्ट, स्पेशली वो वाले चार्ट बनाए जो आप बार बार भूल जाते हैं. राइट? चार्ट को चार्ट के ही एग्जाम निकलेगा आपका, ये चीज याद रखना. ठीक, इंपॉर्टेंट. चलो नेक्स्ट आते हैं हमारे इम्यूनोडेफिशिएंसी डिसऑर्डर्स. इम्यूनोडेफिशिएंसी डिसऑर्डर्स के क्वेश्चन जो आते हैं सबसे कॉमन एग्जाम के अंदर, दैट इज गोइंग टू बी ऑन ब्रूटन्स डिजीज. सो क्लासिकल हिस्ट्री आई टोल्ड यू ऑलरेडी, है ना? Classical history I told you already. You already have this PDF with you here. Why to unnecessarily have that? So X-linked recessive condition है. So B over here, Bruton's disease, B for boys, B for B cell tyrosine kinase. B cells are less. Bacterial infections are going to be there. Patients are going to be having, the lymphoid areas are going to be underdeveloped. Underdeveloped. What has not been asked in the exam, but a very important INI question. INI question, CVID. Everything similar to Bruton's except 3. It is equal for males and females. The number of B cells are nearly normal and the areas are hyperplastic. In B cell, in Bruton's disease, it affects only boys. Common variable, common मतलब common है, वो भेदभाव नहीं करता. No discrimination between boys and girls. No masculinism, no feminism. It is going to be having nearly normal number of B cells, and it is also going to be having hyperplasia of the areas of the lymphoid tissue, like the Peyer's patches, like the lymph nodes, like the tonsils. Then we are talking about a condition that is going to be given the name of selective IgA deficiency. It is the commonest immunoglobulin deficiency disorder. A is the first alphabet. Remember A1. Remember that fact, A1. Right? So A1, that is what you need to remember over here. Right? So A is the number one antibody, right? That is what you just need to be familiar with. And what you need to remember over here is that this is the commonest immunoglobulin deficiency disorder. Commonest immunoglobulin deficiency disorder. How would you get to know about it? Majority of the people you will never be able to detect it. It is normally asymptomatic. A1 here, A1. A first alphabet होता है. मैंने तो नर्सरी क्लास की बात करी है. Right? So A IgA deficiency is the number one immunoglobulin deficiency disorder. Majority of these people are going to be having no symptoms, asymptomatic. वो अपने नाम से बोल रहा है asymptomatic. Some people can have development of life-threatening allergy or anaphylaxis after blood transfusion. So it is mostly asymptomatic, but people can have a development of life-threatening anaphylaxis after blood transfusion. Right? That is what you need to remember. Anaphylaxis को कम करने के लिए हाँ वॉश आरबीसी आप यूज कर सकते हो. That is true अनुकृति. सिलेक्टिव आईजीए की डेफिशिएंसी, लेकिन ब्लड उसको वॉश करने से नहीं जाएगी. Right? D-George syndrome, of course you know that answer. Cas22. Patients are going to be having hypocalcemia. They are going to be having a T cell defect. Hypocalcemia and T cell defect. Right? Whenever I'm talking about hyper IgM syndrome, you are a champion in this now. CD40 problem, CD40L problem. IgM is very high. IgG, IgA, IgE is very less. Job syndrome, that is typically given in the tests. This is hyper Ig syndrome. This is a pediatric condition. The child is going to be having abnormal facial appearance. There is presence of bony issues. The child is having a teeth problem, dentation problem, and the patients are going to be having eosinophils as well. Right? Viscotaltris syndrome. Wiskott-Aldrich syndrome, hot favorite of your examiners. Wiskott-Aldrich syndrome. Again, an example of a condition which is X-linked recessive. So it is going to be causing involvement of boys. So Bruton's and Wiskott-Aldrich syndrome commonly asked in the exam because they love boys, right? This is going to be associated with a triad. What is the triad? The triad that we talk about over here is you're going to be having over here decreased platelet count, thrombocytopenia, high risk of infections, and the patients are going to be having the development of eczema. So whatever way you want to remember water, you want to remember tile, you want to remember it directly. I don't seriously have a problem with that. The point is you must remember the triad. Sensory hearing loss इसमें कहाँ होता है यार? किसी और से कंफ्यूज तो नहीं कर रहे? Bacterial infections, eczema, thrombocytopenia. Another interesting finding of Wiskott-Aldrich syndrome, which is asked the hematology question. If you take the blood sample of these patients and you're going to be looking at the platelets, platelets are very tiny. Chinny mini platelets, small size platelets are going to be seen over here. Right? So patients are going to be having small size platelets. That is what you need to keep in mind. What's the problem in the patients? The problem is in case of a protein. This protein is given the name of VASP protein. Where is the VASP protein present? It is because of the VASP gene. And where is the VASP gene present? It is present on XP. It's present on the short arm of chromosome X. Short arm of chromosome X. That's what you need to know. So extremely important Wiskott-Aldrich syndrome. This was given to you as an image-based question in the exam, a photograph-based question as well of a child having eczema, having a skin rash, having infections, and a male child. And this is also has been asked in the exam separately as a question multiple times. SCID. SCID can be an example of a problem which can be seen because of two reasons. In 60% of the people, it can be an example of X-linked recessive problem. That can be because of interleukin receptor problem, interleukin 2 receptor problem, or interleukin 7 problem. Interleukin 2 receptor or interleukin 7 receptor problem. That's what you need to remember. And in 40% of the people, children, this is going to be an example of autosomal recessive condition. What's the enzyme problem in 40% of people? ADA deficiency. ADA deficiency. Adenosine deaminase deficiency is what is going to be seen in the patients. Now, in these patients, the fundamental problem is both B as well as T cells are going to be defective. Both B as well as T cells are going to be defective. Right? That's what you need to remember. Both B as well as T cells are going to be defective in these patients. Now, we are talking about वो SACD थी डॉक्टर ईशा, वो SCID नहीं है, वो SACD है. Right? That's what you need to remember. So in case of SCID, you're going to be having the presence of adenosine deaminase deficiency. Right? That's what you need to keep in mind. This was a question asked in the exam. So child having the presence of infections, having the presence of a skin rash. And this was a question that was asking you about what is the trouble likely to be seen in the child. So it is having the presence of Wiskott-Aldrich syndrome. Agar infections ho, thrombocytopenia, eczema ka history ho. If you're talking about the presence of a peripheral smear, which is showing you tiny mini platelets, then tiny mini platelets are going to be seen as a finding of a patient who's going to be suffering from Wiskott-Aldrich syndrome. That's what you need to remember. Okay. Then we're going to be talking about amyloidosis, about which you already have a fair amount of idea. So I won't take too much of your time over here, but this is a extracellular pink color deposit over here, which on special polarized light is going to be showing you the presence of apple green birefringence. So under normal light, it is going to be showing you a pink red appearance. Under polarized light, it is going to be showing you the presence of an apple green birefringence. Apple green birefringence. Yeah. Dinner break we're going to be having at around 9:30 or so. Let us just finish GPath first here. So we're going to be having primary amyloidosis. I'm just going to revise those conditions for you. This is going to be quick recap. This is going to be multiple myeloma and amyloidosis, AL. Secondary amyloidosis, you need to remember a condition like TB. The answer is AA. You're going to be talking about a condition in secondary amyloidosis, especially asked in the exam, that is given the name of familial Mediterranean fever. Familial Mediterranean fever. Yeah, if you're talking about a USML exam, step 1 exam, then you remember a condition just given the name of rheumatoid arthritis. In case of CKD, you have to remember about A beta 2. That is what we said. 2 kidneys we are present having a presence of. In case of Alzheimer's, you're going to be having A beta, 1B, 1 brain. ठीक. Medullary thyroid cancer, you're going to be having the presence of ACAL. Now that is where the question has been asked in the exam so many times earlier. Medullary thyroid cancer is the only example of a thyroid cancer arising from parafollicular cells. Right? That was first question. It's an example of a condition in which thyroid is going to get, the amyloid is going to get deposited outside the cells. The third thing that you are going to be asked in the exam is going to be about a condition that calcitonin is going to be a tumor marker for medullary thyroid cancer. Calcitonin is a tumor marker for medullary thyroid cancer. Now, my question for revision for you is that if a patient is going to be having medullary thyroid cancer, then what is the kind of syndrome that the patient is going to be at higher risk of? Mentu syndrome, Himanshu. Very good. Second thing that I wanted to answer is, suppose I have a patient who's having medullary thyroid cancer, but I find that calcitonin is going to be absent in these patients. What is the next tumor marker? What is the alternative tumor marker? Very good. Vaisu, very good. Yes. The alternative tumor marker that we have in calcitonin negative medullary thyroid cancer is carcinoembryonic antigen. Yes, Dr. Soumya, excellent. So that is what I want you to remember. Type 2 diabetes, I want you to remember the patients are going to be having an issue that is going to be AIA-P. Has never been asked in the exam, but you need to remember that amyloid is associated with type 2 diabetes mellitus. That's the only point worth remembering so far as this kind of a discussion is concerned. Familial amyloidotic polyneuropathy is ATTR. Senile systemic amyloidosis is again ATTR. The difference is this one is going to be normal. This one is going to be mutated. Mutated. So when you are going to be having a neuropathy, obviously something is mutated. But when it is related with age is a physiological thing, right? So this is something which is going to be normal. Normal is what is also called as wild. So wild TTR is deposited in case of senile systemic amyloidosis. Mutated TTR is going to get deposited in amyloidotic polyneuropathy. What's the finding that you're going to be getting on the electron microscopy? In case of electron microscopy, you're going to be having the presence of non-branching fibrils. Non-branching fibrils. So they are having a diameter of 7.5 to 10 nanometers, and they're going to be having an indefinite length. 7.5 to 10 nanometers, they're going to be having an indefinite length. That's a point to be remembered. X-ray crystallography. X-ray crystallography. This is going to be showing you the presence of beta plated structure. This is what is going to be showing you the presence of a beta plated structure. It is because of the beta plated structure. That's a question. That's a biochemistry link in case you can remember. It is because of this beta plated structure that you're going to be getting this apple green birefringence. Right? So that's what you need to keep in mind so far as amyloidosis is concerned. Let's quickly have a discussion with regards to the questions which have been asked in the exam in context of neoplasia. Now, whenever we're going to be talking about neoplasia, these are the 4 characteristics that we're going to be having for neoplasia. So a quick recap about the 4 characteristic features of neoplasia. Out of these 4, of course, you are able to remember and recall which is the most classical feature. Then break बाद में कर लेंगे यार, अभी तो 15-20 मिनट है, तो 9 बजे कह रहे थे आप miss. So we are going to be having the presence of the most characteristic feature of neoplasia, that is going to be metastasis, most reliable feature. Most reliable feature. Example of malignant tumors which are not going to show metastasis include basal cell carcinoma, include glioma. They are malignant, but they do not have metastasis. They are malignant, but they do not have metastasis. Whenever we're going to be talking about metastasis, venous spread is much more common in comparison to arterial spread. Venous spread is much more common in comparison to arterial spread. Right? Whenever we're going to be talking about rate of growth happens to be really high in case of malignant tumors. And this rate of growth is going to be dependent upon the presence of a phenomena that is given the name of Warburg effect. Warburg effect. Most of you know the fact. Warburg effect is simply, it is given the name of aerobic glycolysis. Aerobic glycolysis. Why is Warburg effect important? It is important so that clinically you can do a PET scan in the patient. FDG PET scan can be done comfortably. Right? Aerobic glycolysis. Glucose hunger is the second name that is being used over here. So if the examiner is using FDG PET scan, if the examiner is using the term glucose hunger, if the examiner is using the term aerobic glycolysis, he is practically talking about the same thing. Aerobic glycolysis है भाई. Aerobic. Then we are talking about invasion. In case of invasion, it depends whether the basal membrane is affected or not affected. If it is affected, it is called as invasive cancer. If it is not affected, it is called as carcinoma in situ. 2 times asked question, easy one. Carcinoma in situ means no invasion. Whenever we're going to be talking about anaplasia, anaplasia is something that you're going to be having a revision of. It is just going to be an irreversible change. Anaplasia is an example of an irreversible change. And what is suggested by this irreversible change? The irreversible change is going to be suggested of the fact that it is going to be associated with malignant transformation. It is associated with malignant transformation. This is associated with malignant transformation. So you have a normal cell, which is going to be having the presence of a normal cell, which is going to be having the presence of a metaplasia. That means there is a change in the nature of the cell. Arey, kahan chala gaya? Then we are going to be having the presence of, let me reappear. Wait. ठीक है, तुम्हें आवाज तो आ रही थी, ऐसे तुम्हें हॉन्टिंग वाली फीलिंग तो नहीं आई ना? तो डिस्कशन तो हमारा चल ही रहा है. सो द पॉइंट इज दैट we are going to be having the presence of normal tissue in which we are going to be having metaplasia. Then we are going to be having the presence of dysplasia, and then we are going to be having the presence of anaplasia. So these are the four characteristics about which you definitely need to have an idea. ये तो बिल्कुल बेसिक है. Then we are talking about the different examples of factors which are responsible for causing development of a cancer. So different genes which are involved in cancers. Of course, you know that fact that we are talking about the first category of genes in which even if there is a mutation or overactivity of one copy of gene, there is a high risk for development of cancer. ठीक. So that is what is going to be associated with. हाँ, मैं बहुत ऊपर चला गया. मैं कह रहा था सर को बहुत ऊंचाई पे ले चलो, इसलिए गायब हो गया. So we are going to be having proto-oncogenes, and proto-oncogenes के साथ में what we are going to be having over here is 5 types of proto-oncogenes. Now the ones which have been asked in the exam include growth factors, growth factor receptor, signal transduction proteins, nuclear transcription factors, and cyclins. The only way to crack a question in the exam over here is going to be that you have to remember the genes and you have to remember the cancers which are going to be caused by them. That's the way the examiners are asking questions these days. So whenever we're talking about examples, these are the examples. I just have to kind of put a tick over here. As गोगा सर says ना कि मैं तो सिर्फ लाइनें मारता रहता हूँ, ड्रग अपने बारे में खुद ही बताती हैं. तो यहाँ पे भी ऐसा ही हो रहा है, जीन्स अपने कैंसर्स के बारे में खुद ही बता रहे हैं, मैं तो सिर्फ लाइनें मारता रहूंगा कि पीडीजीएफ या सिस जो होता है वो ग्लायोमा कराता है. नीट पीजी 2014 का क्वेश्चन है. Whenever we are going to be talking about epidermal growth factor, this is very, very important. ERBB1 causes lung cancer. ERBB2 is responsible for having a second name HER2/neu that is going to cause breast cancer. We are having the role of HER2/neu also in case of, apart from breast cancer, it is also having now a role in case of gastric carcinoma. Don't forget that. Why do we need to talk about this is because patients are going to be having targeted anti-cancer drugs which are going to be produced against these ones. Right? So ERBB1 is lung cancer, ERBB2 is HER2/neu, that is breast cancer. Now, whenever we're going to be talking about Rett gene, that was asked to you as a question. Rett gene is what you see in a patient suffering from Mentu syndrome. Mentu syndrome. When I talk about Mentu syndrome, automatically it would be associated with medullary thyroid cancer as well. दवाई का नाम बता दो फटाफट. मेडुलरी थायराइड कैंसर की दवाई जो कि टायरोसिन काइनेज इनहिबिटर है, जो कि रेट के ऊपर काम करती है. वंदे मातरम. वीडियो भी ध्यान से नहीं देखते पूरा. वेंटेनेटिव. ठीक है. व्हेन वी आर टॉकिंग अबाउट एएलके, भाई सेरेबेलम का पूरा फायदा उठा लो, नहीं तो क्या होगा ना, मतलब निमोनिक्स बनाएंगे हम बैठ बैठ के, इतना दिमाग लगा के, लिफ्ट में जा रहे हैं, ऊपर जा रहे हैं, ऊपर जा रहे हैं और जाए जा रहे हैं, तो तुम उसको यूटिलाइज तो कर लो. एएलके. So ALK is going to be associated with adenocarcinoma of the lung. Adenocarcinoma of the lung. Then AL is also associated with anaplastic lymphoma. This was also asked as an INA question. And this can be seen in a patient who's going to be suffering from neuroblastoma as well. So ALK is associated with anaplastic T-cell lymphoma. It is going to be associated with adenocarcinoma of the lung as well. Example of a drug which is going to be having adenocarcinoma of the lung, which is caused because of ALK. कौन सी दवाई दोगे? दवाई का नाम बता दो भाई, कोई तो एम्स जाएगा. हाँ, कोई तो निब होगी. कौन सी निब होगी मैं तो पूछ रहा हूँ. एलोटेनिब जेफिटेनिब नहीं है. एलोटेनिब जेफिटेनिब ऊपर देते हैं. क्रिजोटेनिब. क्रिजोटेनिब होती है. यस राजू, वेरी गुड. ठीक है. देन वी आर टॉकिंग अबाउट किट. दिस वाज आस्क्ड एज एन आईएनए क्वेश्चन 2023 में. क्रिजोटेनिब यार, क्रिजोटेनिब. क्रिजोटेनिब इज एंटी एएलके. एलोटेनिब जेफिटेनिब इज एंटी हर1. इट इज एंटी अर्ब1. ठीक है. सो किट इज व्हाट इज गोइंग टू बी एसोसिएटेड विद द पेशेंट हु इज गोइंग टू बी हैविंग जिस्ट and patient who's going to be having seminoma. This was asked to you as a question. Seminoma वाला question आया था किट का. C-kit is going to be associated with seminomatous tumors and it is also seen in a patient having GIST. GIST की drug of choice? फार्मा क्वेश्चन जिसके ड्रग ऑफ चॉइस आसान है ये तो रुमा थोड़ी ना, इमार्टिनेब, इमार्टिनेब. Then we're talking about RAS genes. KRAS is associated with colon cancer, colon cancer. HRAS is associated with bladder and kidney cancer. MRAS is associated with melanoma. BRAF, very, very important from your exams perspective. Very important. Hairy cell leukemia, benign nevus, melanoma. Any other example of cancer which can be caused because of BRAF? हाँ जी, BRAF. बिल्कुल ठीक. Papillary thyroid cancer, that is another one. Apart from that, और कोई example? LCH, Langerhans cell histiocytosis. Very good. So do be aware about these examples. Papillary thyroid cancer, Langerhans cell histiocytosis, malignant melanoma, benign nevus, hairy cell leukemia. These are example of tumors which are going to be having the presence of BRAF. अगर मेरे को BRAF का ये वाला म्यूटेशन देखना है, INI-CT का क्वेश्चन रिवाइज करा दो. BRAF का म्यूटेशन देखना है मेरे को V600E वाला म्यूटेशन देखना है. हाँ, तो ड्रग का नाम बता दिया निष्ठा ने. वेरी गुड. वेमुराफिनेब होती है जो आप देते हो मेलेनोमा के अंदर. So this is going to be detected with the help of what type of a genetic testing? सिंगल जीन म्यूटेशन है तो कैसे टेस्ट करते हैं इसको? सिंगल जीन म्यूटेशन है तो कैसे टेस्ट करते हैं? आरटीपीसीआर से थोड़ी ना करेगी. ना 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 ना. सिंगल बेस प्राइमर एक्सटेंशन टेस्ट. सिंगल बेस प्राइमर एक्सटेंशन टेस्ट. सिंगल बेस प्राइमर एक्सटेंशन टेस्ट. So when you're going to be having a single nucleotide mutation, when you're going to be having a replacement of amino acid one by other, that is best detected with the help of single base primer extension test. ठीक है. सो ये वाली चीज याद रखना. मतलब वो क्वेश्चन आपको देगा, मेरा पॉइंट समझना, वो क्वेश्चन आपको देगा बना के हेरी सेल ल्यूकीमिया का, या क्वेश्चन देगा लैंगरहैंस सेल का, या फिर हो सकता है पैपिलरी थायराइड कैंसर का क्वेश्चन दे दे. एंड देन ही विल आस्क यू दैट व्हिच ऑफ द फॉलोइंग इज द मोस्ट एप्रोप्रिएट टेस्ट व्हिच इज टू बी गिवन सो एज टू मेक अ डायग्नोसिस ऑफ दिस. तो आपको दिमाग लगाना है कि मेरे से पीटीसी का क्वेश्चन पूछा, पीटीसी में बीराफ म्यूटेशन है मेरे को पता है. अब बीराफ के अंदर जो म्यूटेशन होती है V600E होती है, उसको कैसे डिटेक्ट करेंगे? सिंगल बेस प्राइमर एक्सटेंशन टेस्ट. सो इंस्टेड ऑफ आस्किंग यू क्वेश्चन ओवर हियर, मतलब सिकल सेल में आपने किया ये टेस्ट, आपने यहाँ पे किया, तो आपको ध्यान रखना है यहाँ पे जेनेटिक टेस्टिंग से यू आर एबल टू मेक अ डायग्नोसिस ओवर हियर, कंफर्मेटरी डायग्नोसिस. वेंटेनाटिव, काजल, वेंटेनाटिव. JAK-STAT was asked as a question in the exam. This was almost like 3 years back. It is seen in a patient who's going to be having polycythemia vera. That was a standard question, right? So ये सब लोगों को याद रहती है, इसकी दवाई भी याद रहती है, which is very surprising. So aquagenic pruritus is a term, and ruxolitinib is an example of a drug that is being given for these patients. So patient is having a hot shower bath, the skin gets red, and the skin is going to become very itchy. Aquagenic pruritus, right? So JAK2 mutation के साथ में associate करते हो. Ruxolitinib, ruxolitinib is an example of a drug that is going to be given over here. ठीक. Next we have to talk about over here primary myelofibrosis में and ET के अंदर भी this particular mutation can be seen. ठीक. Then we are going to be talking about nuclear transcription factor. Very very important, very very important. सीमिक तो आपको एग्जाम में जाना ही है पढ़ के. बर्केट सिम्फोमा, African child, jaw mass, rapidly growing lymph nodopathy, starry sky pattern, having the presence of that cytoplasm which is going to be having the presence of a royal blue cytoplasm, right? That is Burkitt's. NMIC, neuroblastoma. LMIC associated with lung cancer. Which type of lung cancer? Small cell lung cancer. ठीक. So these are the important things that we need to remember. The point is, look at that table and just revise that table, right? फिर अब हम याद कर लेते हैं हमेशा. अभी तो 3 महान बैट्समैन हो गए. कपिल देव जी जिन्होंने वर्ल्ड कप जिताया था, महेंद्र सिंह धोनी, obviously the greatest of all times, and of course Rohit Sharma adding to the list, but all-time favorite is Dhoni. So धोनी एक अकेला बैट्समैन, अच्छा बैट्समैन, अकेला बैट्समैन कैसे भी अकेला नहीं है यार, वो शादीशुदा हो चुका है, अनोखा कह सकते हैं हम उसको, बिकॉज सुपर कैप्टन कूल, राइट? सो व्हेन यू टॉक अबाउट DEAB, सो धोनी एक अनोखा बैट्समैन, हिटिंग 4s and 6s, ऑफ कोर्स हेलीकॉप्टर शॉट, रनिंग बिटवीन द विकेट्स एक्सीलेंट, नेवर टेक्स अ जीरो, ऑलवेज टेक्स अ रन, राइट? Thala for a reason. Yep. So DEAB, cyclin D, responsible for causing activation with CDK4 and 6. This is most important cyclin that is required for pushing the cell into multiplication phase. Then we are talking about cyclin E, that is going to be CDK2. Yes, he's going to be playing for IPL as well because he says that retiring is out of question as of now. Cyclin A, CDK2, and cyclin B, CDK1. Right? So this is what you just need to have an idea over here. ठीक. Now, where exactly are we going to be talking about the role of cyclin D? Cyclin D is having a role in case of a tumor, and the tumor in which it is going to be having a role is given the name of mantle cell lymphoma. The tumor where cyclin D is going to be having an overactivity is going to be given the name of mantle cell lymphoma. So mantle cell lymphoma, you hopefully are aware, revise करा सकते हो कौन सी ट्रांसलोकेशन है? Mantle cell lymphoma की ट्रांसलोकेशन, young kids going on a cycle, making their parents mental, without wearing by wearing socks they are playing their cycle, 11 and 14. 11, 14. So 11, 14 wearing a socks, going on a cycle, making their parents crazy, that's mantle cell lymphoma, right? That's what you need to keep in mind. Then we are going to be talking about something which is going to be given the name of tumor suppressor genes. Tumor suppressor genes actually are going to be tumor suppressor genes. They are tumor suppressor genes. So there are two genes which are present, which are going to be acting like a brake. And therefore, both the genes have to be mutated for the cancer to develop. That's why double hit hypothesis. That's why double hit hypothesis, right? So proto-oncogene, only one gene mutation can cause cancer. Tumor suppressor genes, both the genes have to be mutated, only then there will be cancer. Who discovered tumor suppressor genes and double hit hypothesis? Knudsen. For which gene? RB gene, right? Different functions of tumor suppressor genes, but basic function is that they are going to control the replication rate of the cell. They are going to control the transition. They are going to control the mitogenesis. They are going to control the blood vessel formation. They will decrease inhibition, invasion, and metastasis. What were the questions asked in the exam? In सब पे question आ चुका है directly, indirectly. The regulation of G1S is a feature of RB as well as P53 gene. What is the location of the P53 gene? 17P. What is the location for the RB gene? Chromosome 13q14. 13q14. P53 causes human cancers, 50% of human cancers, as well as Lee-Fraumeni syndrome. RB mutation causes high risk for development of retinoblastoma as well as, what is the other tumor with RB? जल्दी बता दो फटाफट. Osteosarcoma, blastoma नहीं अनुकृति, ध्यान से क्वेश्चन पढ़ना. Osteosarcoma, right? When we are talking about DNA repair is going to be associated with BRCA1 and 2. BRCA1 location क्या होती है जल्दी से बता दो. Ladies first, 17q. When we are talking about BRCA2, 13q. Females are going to be having high risk for development of ovarian cancer as well. They are going to be having, males are going to be having high risk for development of prostate cancer as well. Then it can be associated with MLH and MSH. MLH, MSH associated with the term microsatellite instability, colon cancer, Lynch syndrome. Mitogenic pathway inhibition. Mitogenic pathway inhibition. Mitogenic pathway inhibition is a feature of APC gene. Gatekeeper of colonic neoplasia. APC gene. Gatekeeper of colonic neoplasia. Right? If there is a mutation over here, high risk for development of colon cancer. Why? Because patient has FAP syndrome. Right? Of course, this FAPing is different. This is FAP syndrome, familial adenomatous polyposis. Chromosome 5q. NF12 neurofibromatosis. Neurofibromatosis. When we are going to be talking about P10 gene, Cowden syndrome. Cowden syndrome. P10 syndrome, Cowden syndrome. When we are talking about PTCH, this is associated with development of which kind of cancer? PTCH. जल्दी से बताओ भाई. Revise करा दो PTCH. PTCH is going to be associated with, yes, basal cell carcinoma. And basal cell carcinoma के साथ में कौन सा syndrome होता है? Gorlin syndrome. Gorlin syndrome. G-O-R-I-I-N. Gorlin syndrome. So PTCH के साथ में बोल SMAD. SMAD is going to be associated with development of polyps. SMAD is going to be associated with development of polyps. What kind of polyps would you associate with SMAD? What kind of polyps would you associate with SMAD? Of course, juvenile polyp. Right? So obviously you are cracking the answers very comfortably. Then INI question, angiogenesis inhibition, VHL. VHL is associated with, VHL is going to be associated with development of which kind of a cancer? Cerebellar hemangioblastoma, renal cell carcinoma. Which type of kidney cancer? Which type of renal cell carcinoma? Clear cell cancer. So that was a question asked in the exam. It can be associated with SDHB. SDHB is associated with hereditary paraganglioma syndrome. मेन क्लास अटेंड करी थी मिशन की, तो आपको याद आ जाएगा कैंसर. हेरिडिटरी पैरागैंग्लियोमा सिंड्रोम. कौन से दोनों कैंसर थे? कौन से दोनों कैंसर थे? हेरिडिटरी पैरागैंग्लियोमा के अंदर कौन से दो कैंसर थे? एक था फियोक्रोमोसाइटोमा, दूसरा था जिस्ट. वेरी गुड विपुल. फियोक्रोमोसाइटोमा, दूसरा था जिस्ट. Pheochromocytoma plus GIST is given the name of hereditary paraganglioma. Then we are talking about STK11. STK11, INI question 2022. Associated with the presence of a polyp which is given the name of Peutz-Jeghers polyp. Peutz-Jeghers polyp, Please-Jeghers polyp. Invasion metastasis. Invasion metastasis के लिए क्या चाहिए होता है? Invasion metastasis के लिए चाहिए होता है epithelial mesenchymal transition. अगर इन्वेजन और मेटास्टेसिस करना है तो क्या चीज चाहिए? एपिथेलियल मेसेनकाइमल ट्रांजिशन. व्हाट विल कॉज एपिथेलियल मेसेनकाइमल ट्रांजिशन? Epithelial mesenchymal transition is dependent upon factors. Twist your body, move like a snail. Twist and snail. INICT questions. Snail and twist. Very good, Kajal. अगर इसको इनहिबिट करना है हमें, if you want to inhibit it, then we require CDH1. So invasion and metastasis, if that has to be promoted, that is done with the help of twist and twist and twist, right? Here we twist like a snail. And when we are talking about inhibition, then it is going to be done with the help of CDH1. What's the problem if a patient is going to be having CDH1 mutation? Breast cancer, gastric cancer. Breast cancer, gastric cancer. What type of breast cancer? Lobular. What type of gastric cancer? What type of gastric cancer? Diffuse gastric cancer. Diffuse gastric cancer. Right? So आप देख सकते हो पूरी की पूरी टेबल ही आईएनएसईटी में आ चुकी है ऐसे कैसे. पूरी की पूरी टेबल ही आईएनएसईटी में ऐसे आ चुकी है. राइट? दैट्स व्हाट यू नीड टू कीप इन माइंड. ऑफ कोर्स इसमें कथा कहानी हो चुकी है हमारी. ये वाली हो चुकी है, ये वाली हो चुकी है. एपोप्टोसिस आपने मेरे को पढ़ाई दिया. P53 लीफ्रामेनी सिंड्रोम, BCL2 follicular lymphoma. Right? That's what it. No, Venkat, it is not necessary for you to watch the lab 2 year. You can just go through the notes if you are able to understand them. This is just for our discussion because intermittently we have a discussion about other things as well, right? Defect in the gene repair, very, very important. Autosomal dominant, autosomal recessive. This is what I want you to remember. This was a INA question. This was a INA question. STK11 Michelle is Peutz-Jeghers polyp. So that table is not supposed to be remembered, but I want you to remember is MLH and MSH are example of single stranded repair genes. I want you to remember this. Single stranded DNA damage repair genes, MSH, LH. These all are other examples of double stranded DNA repair genes, double stranded damage repair. Right? So ATM is going to be associated with ataxia telangiectasia. Ataxia telangiectasia. BRCA is associated with breast cancer. That's what you need to remember over here. Apart from that, the easy question is autosomal dominant and autosomal recessive. I hope this one is easy for you. Autosomal dominant is Lynch syndrome. Autosomal recessive is big facts. Bloom syndrome, Fanconi's. Bloom syndrome, Fanconi's, ataxia telangiectasia, and xeroderma pigmentosa. Bloom's, ataxia telangiectasia, Fanconi's anemia, and xeroderma pigmentosum. So that is what is known to most of you. Right? तो टेबल में वैसे ये वाला पॉइंट था जिसको आपको थोड़ा सा ध्यान रखना है, which is with respect to the presence of the MSH, MLH. MSH, MLH are example of which category of genes? They are example of mismatch repair genes. These are examples of mismatch repair genes. Yeah, we're going to be having a break, don't worry. टेबल, ये पूरी टेबल पढ़नी नहीं है भाई, याद नहीं करनी है टेबल. टेबल का पर्पस सिर्फ इतना सा था कि आपको पता होना चाहिए. टेबल में आपको पता होनी चाहिए सिर्फ 3 चीजें. टेबल 3 चीजें पता होनी चाहिए आपको. Point number 1 which I want you to remember over here is going to be a simple fact. Whenever we are talking about mismatch repair genes, whenever we are talking about mismatch repair genes, it is MSH, MLH. Mismatch repair genes, MSH and MLH. Right? Second thing which I want you to remember over here is that whenever we're going to be talking about nucleotide excision repair genes, you need to be familiar with xeroderma pigmentosum. Xeroderma pigmentosum. Nucleotide excision repair genes, xeroderma pigmentosum. Right? That is what you need to remember. It is again an example of a single stranded xeroderma pigmentosum. At any point of time, when you're going to be talking about, the BRCA genes, then BRCA genes are going to be example of recombination repair genes. BRCA genes are example of recombination repair genes. Right? These are the ones that you are supposed to be keeping in mind. बहुत ज्यादा टेबल को नहीं ध्यान देना, इस चीज को ध्यान देना. फाइनल चीज उसकी हम बात कर सकते हैं before we can go in for a meal break so that you don't miss out on your, meals is going to be something like this. Warburg effect is glucose hunger, already discussed. That is useful in case of 18 FDG PET scan. या तुम बोलोगे तो न्यू क्लास खत्म ही कर लेते हैं गेस टू से, राइट? एरोबिक ग्लाइकोलाइसिस. Oncometabolite formation is dependent upon an enzyme. It is 2-hydroxyglutarate. It is 2-hydroxyglutarate that we just need to keep in mind. 2-hydroxyglutarate that we have to keep in mind. And this is something which is going to be associated especially with respect to the enzyme that is involved over here is isocitrate dehydrogenase. Isocitrate dehydrogenase. So especially important in context of the blood cancers, as well as in case of brain tumors, blood and brain tumors. Oncogene addiction is a term that you associate with a cancer like CML. So in CML, you know that the tumor cells are dependent upon tyrosine kinase overactivity. That is why they are able to survive. If you are going to block the tyrosine kinase activity, tumor cells do not survive. So that is why they are going to be getting crushed when you give a drug like imatinib. Differentiation therapy is dependent upon acute promyelocytic leukemia. Acute promyelocytic leukemia. So translocation, which translocation is seen over here? Vitamin A underactivity, 15-17. 15-17. So you have to give vitamin A from outside. Vitamin A from outside. Then we are going to be talking about an example of a condition that is given as chromothripsis. Chromothripsis is chromosome shattering. Bone tumor, brain tumor. Bone tumor, brain tumor. Chromosome shattering. Rearrangement of the chromosomes in different ways. Yeah. Then we are talking about epigenetic changes. Epigenetic changes, DNA methylation, histone deacetylation. Which of these two activities is present in case of sirtuins? Histone deacetylation. Histone deacetylation, right? That's what we talk about. So these are epigenetic changes. Now, epigenetic changes are the changes which are important because they also influence the functioning of the genetic material. So any type of a bad food that you're eating, any type of a pizza, burger, cola that you're eating, any type of smoking that you're doing, any type of alcohol that you're consuming, definitely is going to produce changes at the level of epigenetics. Epigenetic changes have been noted over here. Reverse is also true. The day you quit any of these bad habits, the day you start exercising, your epigenetic changes are going to be moving in the healthy direction. So why is this important? Because this is going to be influencing the activity of the DNA in a good manner, right? Oncometabolite hota hai yaar, it is an example of oncometabolite, matlab cancer causing metabolite. Cancer causing metabolite. So you have activity of an enzyme that is called as isocitrate dehydrogenase. If this is going to become overactive, then cancer causing metabolite is produced more. If cancer causing metabolite is produced more, high chance of cancer. So whenever there is an IDH mutation, it is seen in case of blood cancer, it is seen in case of brain tumors, then patients are at higher risk for development of cancers. IDH mutation is associated with higher risk for development of cancers. That's what you need to remember. Okay. Then we are talking about the causes, chemical carcinogens. APL is acute promyelocytic leukemia. Chemical carcinogens, microbial carcinogens, and radiation-induced cancer. The example of a chemical test which will tell you that a particular chemical can cause cancer or not in humans is given the name of Amy's test. Chemical carcinogens, right? Lots and lots of chemical carcinogens that have been asked in the exams, and you have a good list that you just need to kind of recall. Microbial is going to be important because bacteria are bad, fungi are bad, parasites are bad, viruses are bad. But out of them, which is the most notorious? The most notorious happens to be viruses. Very, very dangerous. Viruses are the most dangerous. Right? Radiation-induced cancer, most damaging are ionizing radiations. Exactly what I've been mentioned over here. So these are just example of information that you have been asked in the exam earlier. I don't think I have to kind of read them out again, except for a couple of them. And the couple of them I want you to remember over here very clearly is going to be with regards to Epstein-Barr virus. This is what people tend to remember. Hodgkin's, non-Hodgkin's, endemic burkitt's, and esophageal, and add in the list stomach cancer also. Add in this list stomach cancer. That's one important thing. E6, E7 here, CS cervix के अंदर. E6 causes underactivity of P53. E7 causes underactivity of RBG. The second one which I want to remember now, EBV is important for NEET PG exam. HSV is important for NEET PG as well as INI-CET. Kaposi sarcoma, 99% people remember. Kaposi sarcoma, 99% people remember. People tend to forget this. This was asked as an INI question. Primary fusion lymphoma and multicentric Castleman disease. Primary fusion lymphoma and multicentric Castleman disease. This is what somebody was talking about already, the fact. And of course, the question asked in the exam as the microbiology correlation was that you are going to be having the vaccine which is going to be giving you protection against human papilloma virus, because the vaccine is going to be working against L1 capsid protein. The vaccine is going to be working against L1 capsid protein. The rest is what people find easy for most of them to remember and recall in the exam. Right? So nothing spectacular that I have to add over here except these two EBV, HHV. This is just for the sake of a recap, because this is what we discussed in the beginning. CK7 and CK20 are useful for differentiation of carcinoma of unknown primary. And the only question which has been asked in the exam so far on this is with regards to cancer that is given the name of colorectal carcinoma. It is CK7 negative, 20 positive. Right, so I hope you remember that CM जो है वो 20 दिन काम करेंगे, एक हफ्ते की छुट्टी पे जाएंगे, बाकी दिन का पता नहीं. So this is what you need to remember. C for colorectal cancer and M for Merkel cell cancer, which are going to be CK20 positive, CK7 negative. CK7 negative, CK20 positive. That is what is to be kept in mind over here. Right? Ouch, pouch. Both positive, ouch. Pouch. Pouch is what is going to be helping you remember the fact patients are going to be having cancers like pancreatic cancer, ovarian cancers. They are going to be having the presence of the cholangiocarcinoma. They are going to be having the presence of. So CH is for cholangiocarcinoma, P for pancreatic cancer, O for ovarian cancer, U for urothelial tumors. Right? Both positive. Both markers are positive. I need a break more than you. Don't worry. Break चाहिए, सबको चाहिए भाई. That there are people who are attending the class for the first time. So for those people, I'm just making a mention of these markers. These are the ones which are most important from the perspective of the exams. These are the most important ones. So 99% chance that when you're going to be asked a question in the exam on the special markers, higher probability that you'll be given a question on something like lung cancer. So lung cancer, as all of you understand, lung cancer A1 cancer hota hai, adenocarcinoma. That's why TTF1 nuclear staining with napsin A and SPA1. Right, A1, TTF1, SPA1, napsin A. When we are going to be talking about neuroendocrine tumors, chromogranin, synaptophysin, CD56. We call an example of an IRA question, which is an example of an intranuclear neuroendocrine tumor marker. Intranuclear special marker. Intranuclear special marker. नाम से बता रहा था आपको. इंट्रान्यूक्लियर स्पेशल मार्कर INSM1. इंट्रान्यूक्लियर स्पेशल मार्कर, इसका नाम इंसिनोनोमा लाइक पेप्टाइड है, but just for the sake of our understanding and just to remember it, intranuclear special marker is INSM1, which is a marker that is going to be showing you nuclear staining. It shows you nuclear staining in context of neuroendocrine tumors. Neuroendocrine tumors. So far as mesothelioma is concerned, this is what you need to keep in mind. Mesothelioma, calretinin. WT1. 90% chance people will fumble if they don't have an idea. WT1, of course, is Wilms tumor 1. But apart from Wilms tumor, it is also associated with mesothelioma. And you're going to be having a marker like D240. Very, very important. This is very, very important. Finally, squamous cell carcinoma associated with P53 mutation. So P53 mutation, bada bhai, choti bhen, as I always say that, bada bhai is P63, big brother. Choti bhen is P40, that's a marker. And squamous cell cancer, cytokeratin 5-6. So cytokeratin 8-18, I just recall that. Cytokeratin 8-18 is Mallory-Denk body. Mallory-Denk body. When I'm talking about cytokeratin 7-20, that is for CUP, carcinoma of unknown primary. When I talk about cytokeratin 5 and 6, 5 and 6 is for squamous cell carcinoma. That's what you need to remember. Right? These are the special examples of translocations that are supposed to be kept in mind over here. An example of previous questions. This one is APML. Quick recap. This is APML. This one, of course, is going to be CML as well as ALL. This one is going to be Burkitt's. What is the technique that we are finding over here? The technique that we are representing over here is going to be FISH. This technique is going to be given the name of FISH. Fluorescent in situ hybridization. And this was a pediatric path question. The child was having an ocular tumor. He underwent a biopsy and he underwent a tumor. He underwent a biopsy which showed a tumor which was Desmin positive. So when you're going to be talking about a Desmin positive tumor, of course, you're going to be talking about a rhabdomyosarcoma. Rhabdomyosarcoma. Right? Flow cytometry, very, very useful for making a diagnosis of lots of hematological disorders. and especially the ones because of which we are going to be having a detection of CD molecules. Right? So that is what you have to talk about so far as a flow cytometry is concerned. Of course, you got an easy question exam. Some of you already know it on tumor markers. So beta hCG is a tumor marker for choriocarcinoma. This was INI-CT match the following question. Beta hCG is a tumor marker for choriocarcinoma. Calcitonin is a tumor marker that we are going to be having for calcitonin for medullary thyroid cancer. Of course, you know that. Hepatocellular carcinoma, you are having alpha fetoprotein. Hepatocellular carcinoma, you're going to be having alpha fetoprotein. And then you got a question of markers for pheochromocytoma, catecholamines. So easy questions, not very difficult, but of course, you must know in order to know them, right? So this is like 9:15 as of now. Let's take a 20-minute dinner break and then we come back for our resumption. ठीक, वापिस आ रहा हूँ. उतना ही खाना खाना है, ज्यादा मत खाना, नहीं तो सो जाओगे. उतना ही खाना खाना है भाई, 45 मिनट्स खाना नहीं खाना है. वापिस भी तो आना है ना, हिमायत करनी है. अच्छा 30 मिनट्स कर लो उसको. 20 मिनट खाना खाना, 5 मिनट अच्छी सी कॉफी पी के आ जाना. 5 मिनट लंबी सांस लेके आना. हाइपोक्सिया इज द कॉमनेस्ट कॉज ऑफ सेल इंजरी. राइट, सो वी स्टार्ट एट, अब तुमने 9:16 कर दिए, 9:41, 9:46. ठीक है, जल्दी आ जाओ. बाय बाय. क्लास ये टॉपिक खत्म करके यार करेंगे, हिमायत तो खत्म करेंगे यार. 2 दिन के अंदर करना है भाई. लैप मतलब भागना है, स्प्रिंट है या डैश है. राइट, चलो भाग जाओ खाना खाने. बाय बाय.